Welcome, 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 everybody, to another Sunday of When Black Women Gather. My name is Helen Higginbotham, and for those of you, it's your first time here. We invited men into this circle, but we're a women's organization, and we get together and talk about all kinds of topics that are relevant to us as a community. And the topic that we have today clearly is important to all of us. So men and women will be here today. And our guest is the esteemed Dr. Eve Higginbotham. And yes, we have the same name. Isn't that special? The beauty of having that 12 letter name, right? When you
Yeah.
meet a Higginbotham, you're like, wow. So I'll tell you in a minute how I met you, how I met her. But today we're going to talk about glaucoma. It's the silent thief of sight, and it's important to me because I found out by chance. I was one of these people who never miss an annual appointment with my optometrist, and he never diagnosed that I had not only glaucoma, but I had an advanced case of glaucoma. Um, and it wasn't until he was actually savvy enough to notice that I had a torn retina, and that sent me to an ophthalmologist instead of an optometrist. And that's how I discovered this. So we are going to talk today, and that's how I got to meet Dr. Eve, which is just a whole nother story. Welcome, Dr. Eve.
Thank you. Glad to be here. Thanks for having me, Helen.
Oh no, thrilled to have you. Thank you for making time. And I do know that this is the pre-Super Bowl Sunday or what have you. So for all of you who are here, thank you for giving up your time. But anyway, Dr. Eve is going to talk to us today. She's a glaucoma specialist. She's going to talk to us about glaucoma. We're going to do an informal conversation. So any questions that you have, feel free to jump in. I'm going to introduce her and let her give us an intro to talk about glaucoma, what it is, what are the signs we should be looking for, what are the causes, why is it prevalent in the Black community, more male, more female, all kinds of questions. But real quickly, Dr. Eve and I share the same last name, and I met her by chance because I was applying for a job. She also works at University of Penn, and I was applying for a job. And as I was doing my research to get ready for the job, I'm like, there she was, the same name. And then, it was just by chance I had just found out that I had glaucoma. And here's this lady named Dr. Higginbotham, and she's a glaucoma specialist. So, of course, I called her, and of course, she responded. So, here we are. But let me tell you real quickly who she is. She is the inaugural Vice Dean of Inclusion, Diversity, and Inclusion at the Perelman School of Medicine at University of Penn. So that's how I met her. I was looking at a DEI job at Penn myself. And she is also a senior fellow at the Leonard Davis Institute of Health Economics and a tenured professor of ophthalmology at the University of Penn. She is an elected member of the NAM Council and member of the AAAS. She'll tell me what that means. Dr. Higginbotham is also a member of the board of directors of Ascension, chairing the quality committee for the system. She previously served tenures on the Harvard Board of Overseers and the MIT Corporation. She is a graduate of MIT with what SB? What is that? Tell me.
It's a bachelor's, but it's the Latin. Yeah,
The
that's
other way.
the way to
Okay.
do
All right. I'm like, that's new.
it. Yeah.
She also has an SM in chemical engineering and an MD from Harvard Medical School. She completed her residency in ophthalmology at LSU and a glaucoma specialist fellowship at the Massachusetts Eye and Ear Infirmary in Boston. And in 2020, this is lady's a high achiever. In 2020, she completed her master's in law degree from the University of Penn. Okay, what haven't you done, Dr. Eve?
Thanks,
That's
Helen.
impressive.
I'm going to call you cousin because, we have to be cousins, right?
That's right.
So,
So,
um,
yeah.
when Helen reached out, I said, yes, of course. This is actually National Glaucoma Awareness Month that's been established by the National Eye Institute. And so what I'd like to do is just be very informal, and hopefully you'll have lots of questions. And, certainly I'm one who usually uses slides. I did make one slide today, Helen. I know I said I wasn't going to use any, but sometimes a picture does help. But what I thought I might do is just start generally talking about glaucoma and why it is for us to really know about this particular eye condition for our community, and how as women, we have not only a greater likelihood of developing it, but the fact that it's so prevalent in our community. It occurs so often. And I know many of you are the ones in your families that's telling your brother, your uncle, your father, have you had your eyes checked, or have you had your physical exam this year? We tend to be the caregivers, right, of our family. So it's a matter of actually recognizing that it's not just your heart, and it's not just your getting those colonoscopies. It's not just getting your your EKG done, getting your hearing checked, but it's a matter of also getting your eyes checked, particularly as we get older. So glaucoma actually refers to a group of eye diseases, because you can have various kinds of glaucoma. But the most common that we see in our community is called open angle glaucoma. That's where the drainage area in the eye is actually open, but it's not functioning as well as it should. So the pressure inside the eye can actually go up over time as we get older. And so particularly if you're over 40, that's where things start changing a lot. And as we get into the older, even older years, there's a greater risk. So age is a big risk factor. Family history is another big risk factor. If you have a family history, there's a 7 times greater chance that you may develop glaucoma. And so with that family history, it might actually start earlier. It might start before 40. So it's a group of eye diseases that can lead to blindness if it's not treated early. And that's why conversations like what we're having today are so important, because you don't know what you don't know. I mean, if you're not actually keeping track of, how you're seeing out to the sides of your vision, which what we call the visual field, you're not going to know until the later stages. So I've been a glaucoma specialist my entire career, and I know that it's going to be an amazing shock to you, but I've been doing this for 40 years. More than 40 years. I did my residency in my hometown of New Orleans at LSU Eye Center going back in the 80s. And we had this public safety net hospital called Charity Hospital, got destroyed in the hurricane. So it has an open sense, but Hurricane Katrina, I should say. And so when I remember as a resident, I would see patients, and they were all patients that I could be in my own family, that looked like me, that could be part of my family from our community. And they would come in for their first eye exam that could be like, in their mid-40s. And I have to tell them that they're legally blind. So how does this happen? It happens because in glaucoma, you start losing your vision from the side. And you can have 20/20 vision and still have advanced disease. So that's why it's called a sneak thief of sight. And so the other thing to think about is that you have 2 eyes, and the 2 eyes work well together. One can really help the other in terms of some of the visual field, but it gets to a point that visual field is so small that it's not going to help. Okay, so there is, I think, some cushion there that's built in that makes you think your eyes are okay even later, because the two eyes are working together to help you see. So unless, say, I'll tell you a story about one of my patients that came in late, and they said, doc, I was driving and I noticed when I looked to move over to my right, I can't really see as well as opposed to my left. Okay. And all of a sudden there was like this 18-wheeler truck on my right-hand side and I didn't see it. And so that would suggest, even before we do a visual field and any testing, that person's visual field in that right eye is basically gone or significantly less. So you don't really know what you don't know until you go, basically. And so it's a matter of actually recognizing that when you get to a certain age, and I would just say, if you haven't had a comprehensive eye exam, and if you have any questions, I'll see, this is something in the chat now.
Yeah, I'm watching the chats for you, so I'll keep you.
Oh, good. Just let me know
I will.
if there are any questions that come up, because I want this to be more of a
Already, someone's saying they want to know the difference between an optometrist and an optometrist. And I think I know I made an assumption. So can you give us that clarity?
Sure. So as you heard from my my introduction, I went to medical school. So optometrists don't go to medical school. We all have gone to college. And then once you decide what you want to do, it's a quicker track to go to optometry school because you don't have to go to medical school. I didn't know that I loved the eye so much until I went to medical school. So my track, and for ophthalmologists, it's medical school. So we learn everything about the human body and we treat patients. I treated patients in the intensive care unit, as part of my training. So I have the knowledge of the whole body going through medical school. And then I did an internship, which I did in San Francisco years and years ago, and took care of patients that were going to have kidney transplants as part of my training. And then I did my residency in New Orleans. So that's 4 years of medical school, another year of internship, and then 3 years of residency. Plus, I did 2 years in addition to my 3 years of residency in New Orleans, where I took care of patients with eye trauma and eye diseases, and that was my focus. I decided I wanted to focus on glaucoma because it's such a leading cause of blindness for our community. And it would break my heart to see patients that, like I said, I could see as part of my family coming in and they were already blind. And so I wanted to be a glaucoma specialist for my career. And so I went up to Boston for 2 additional years. And so that was my training as an ophthalmologist. Just to review, 4 years of med school after college, a year of internship, 3 years of residency, and then 2 years as a glaucoma fellow at Massachusetts Eye and Infirmary in Boston. And then I had my first job at University of Illinois. For optometry, it's usually 3 to 4 years. And I say 3 to 4 because I don't know where they are at this point, because I know there's some interest in shortening some training. So 3 to 4 years of optometry school, and there are optometry schools all over the country. And then they may or may not decide to do a fellowship. They may do a fellowship or residency in a VA hospital, usually. They'll do their residencies, but there are freestanding optometry schools where they have 1 or 2 years of residency. So you will see optometrists in the community that have glaucoma training, but they will be called ODs, but they still are called doctor. And they can prescribe medicines, I would say, in most states, if not all states in the United States.
So that's interesting because my doctor, when I finally did go see, and mind you, I adored my optometrist, and I move a lot, but no matter where I lived, I always came back to see the exact same optometrist. I mean, that's how comfortable I was with him. And it wasn't until I went to the ophthalmologist, after the torn retina, that I ever had a visual field study. He was just doing that balloon thing where it goes and then it pops in your eye. That was it. And by doing that, according to his interest, I guess the pressures were normal. So two things. One, how do we know that the optometrist is, at what age should we start seeing an ophthalmologist? And are there ophthalmologists who don't do, because one person I saw who's an ophthalmologist, when I asked her to prescribe my glasses, she was like, I don't do that. Like it was
Oh,
beneath her. So I still had to see an optometrist. Um, and so what kind of tests should we be asking for? Because we don't know. We're lay people. I'm just going to the eye doctor. I have no idea that you're supposed to be doing, this exam, not looking at, I never even heard any talk about an optic nerve until I saw the ophthalmologist. And the last thing I want to ask you too, I know I'm long-winded, when you were talking about being at the hospital where you were dealing with, being a doctor and having understanding of the entire body. Can we talk about what's connected, the holistic effect of it? When I'm ignoring my eyes, what are the other things that are affecting my body, or what other kinds of things can be affecting my vision? So sorry, that's a lot of questions.
yeah, and we're getting a lot of great questions in the chat too. So I'm going to try and cover them. So Helen, hopefully you can help me because I'm speaking without notes or anything. So we'll make sure that we cover as much as we can. But let me just say from the outset, they're good ophthalmologists and good optometrists. And I would say at this stage in my career, my wish is that all of us could be better educated in terms of what we need to ask. And so that's what I'm hoping that we can accomplish today, is to be able to ask the right questions when you see either an optometrist or an ophthalmologist. Because as I said, there are optometrists who have glaucoma training who can certainly manage glaucoma patients, particularly those that are stable. And at the end of the day, if you're in a good treatment regimen, 90% of glaucoma patients will be fine. But it's a matter of keeping track as well as early diagnosis. So hopefully that answers the questions about optometrists and their initials are usually OD. And for ophthalmologists, you can either see an MD after their name or an osteopathic doctor, a DO. I know that's all confusing, but we have osteopathic doctors and allopathic doctors, MDs and DOs. And so glaucoma is one of the things that's looked at, particularly those of us of African descent who go into the doctor because we are at higher risk for developing glaucoma. Okay, so once you have an appointment, you decide to go, what are the expectations? First of all, they're going to ask you about your family history. And I would ensure that if you don't know your family history, ask your family about their eyes at the next family dinner. in terms of whether or not they're experiencing any blindness, or did we have in our family anyone who was blind? Blindness for me as an ophthalmologist, when I hear family history, is an important thing to note, okay? Because that would suggest that there was severe eye disease in the family. And so if you have a family history of glaucoma, and that's the other thing, let me just kind of go back a little bit on family history, since so many of us in our community, and even as you look around the world, particularly, since we had the history that we had with slavery and all the issues with racism, which certainly racism doesn't stop at the door of medicine either. So there's been so much in our country that has limited our access to services. That's one of the reasons why we have a higher incidence. It's really more what we call now social determinants of health that have limited our access. And so if you know your family history, make sure you talk about that and make sure you tell them that there is a history of blindness. The other thing that they'll ask you are about your other conditions that you might have. If you have diabetes, if you have hypertension. Certainly, if you have diabetes, there's a particular kind of glaucoma you can develop, but diabetes can also lead to blindness on its own in the back of the eye, in the retina. And that's another discussion. So if there's a history of a family history of diabetes, or if you have diabetes, that's a big thing to actually put on the chart or make sure that's captured. And then they'll ask you about whether or not you've noticed any changes in your vision. Now, as we all get older, particularly as women post-menopause, we may have more dryness of the eyes. Dryness of the eyes can blur your vision. So, when you think that, oh my God, I'm having some difficulty seeing, but it's not every day, it's just certain days, and it's sometimes at the end of the day, it's not at the beginning of the day. Dry eyes, as someone just put in the chat, is very, very common. And I find that's what a lot of people underappreciate as a major reason why they have blurriness of their vision. So that has the simplest solution, and that is to go to the drugstore and get an over-the-counter artificial tear. I don't get anything for mentioning a particular name of a brand, but Systane is one that I've used, or at least have recommended to patients. Artificial tears you can use often. You can't overdose on those. So it's a matter of actually ensuring that you're putting artificial tears in frequently, particularly in the time of the year that we're in now, like in January where the weather's dry and we all may have dry heat in our houses. You might need to put artificial tears in more often. So I may have patients put it in every 2 hours just during the day. And it's amazing how that can make a difference. Okay. Now, if you've had some slow decrease in your vision over time, let me kind of back up a little bit. If you're around the age of 42 and you're just getting your first eye exam and you notice that you have difficulty seeing things up close, that means that you are developing presbyopia. That means that the muscle inside your eye is not squeezing your lens as much as it should, so it's not allowing you to see things up close, and you have to put things far away to be able to see it. That's okay, because everybody goes through that. The average age is 42, and if you tend to have had previous to that normal vision where you didn't need any glasses, it may happen a little earlier. Or if you're like me, nearsighted, and I've always worn glasses since I was a kid, then you might be able to push it back until you're 50 before you might need reading glasses. So the need for reading glasses does not mean you have a brain tumor. Okay, I've had patients come into the office like, oh my God, I'm freaking out. I can't see. And I said, okay, you're fine. After the whole exam, of course, you're fine. You just need some reading glasses. And it's okay. If you have really good vision that you can see, particularly when you're driving, in most states, you only need at least 20/40 vision. So not everyone needs glasses to drive or at least see at a distance. Then you can just pick up at Sam's Club or Costco's, the readers. You can get 10 for $20. I don't know what they are. When I first started suggesting that when I was a resident, my patients would look at me like, why is she telling me that? I want something expensive. If the only thing that you need are reading glasses, those glasses are fine. And I usually start people at plus 1.25.
Mhm.
And then every couple of years, you might have to go up like plus 1.5 and 1.75 and 2. Just bring something to the store that you can read, like your phone, and see if that helps or not. And so over-the-counter reading glasses are fine for those that are fortunate enough to have healthy enough eyes to be able to just use reading glasses. Okay, so they'll ask you about any change in your vision and whether or not you have a family history, as we discussed. And then they'll start checking your vision, and they'll determine whether or not, when they put the lenses up, if they can get you to see better. If they can get you to see back to 2020 or 2015, then that's a good thing, okay? But then as they do more steps in the exam, they'll look at the front of your eye through the slit lamp, through the magnifying instrument that we use. They'll check the pressure. Now, as an ophthalmologist, we don't usually use the air puff tonometer to check the pressure. We use either a small instrument called a tonopen, or we might actually put orange dye in your eye and use the applanation device on our machine, which is the most accurate, to be honest. So when they put that orange dye in, so they'll check your pressure. Now, sometimes the pressure may be high. So what's a high pressure? The average normal pressure is 16. 16 is a number to think about. But then what we call 2 standard deviations beyond that goes up to 21. And in the old days, when I was learning the field, we would say anything up to 21 was considered normal. But normal for you may not be normal for me. Okay, so now I'm going to start getting into a discussion about how pressure doesn't necessarily have to be high to have glaucoma. It could be normal pressure. It could be 16. It could be 17. You could still have glaucoma. So pressure is not the end all. Okay. So, they'll say, oh, your pressure is normal. As they said to you, Helen, your pressure is normal. Okay. Well, that's fine. Your pressure fluctuates during the day. So sometimes the pressure could be normal in the afternoon, but high in the morning. But if you always see the optometrist or ophthalmologist in the afternoon, we may miss the times when your pressure may be normal or higher, I should say, or higher, which might be in the morning. 2/3 of people, it's a little bit higher in the morning. So the pressure is okay. And then they'll look at the lens inside your eye. We have a natural lens. Your eye is like a camera. So it's like a lens inside the eye. will probably dilate your pupils. So that's what I mean by a comprehensive eye exam. When we dilate your pupils, those are the times when you walk outside. You don't have those special sunglasses that they give you, or if you don't have your sunglasses, it's going to be bright, okay? But it's not forever. It's only for a couple of hours as the drops wear off. But the dilation allows us to make the pupil inside your eye bigger so we can see more in the back of the eye. So they'll look after the dilation occurs, and it usually takes about 25 minutes or so. They'll look in the back of the eye, and they'll look at the lens as well, you know, as they're looking at the back of the eye, the lens which is like the lens in your camera. If it's, you know, if as adults, we all have a little bit of cloudiness of the lens. That's what a cataract is. A cataract is when you have clouding of the lens. You couldn't live on this earth with all the UV radiation, ultraviolet radiation, and not have a little cloudiness of your lens. So don't freak out if they say you have a little cataract, because we all have some clouding of the lens. The key is whether or not they were able to correct your vision with lenses to 2020 or to 2030. If you don't have any issues with, you know, the things that help you to function on a daily basis, you can continue to live with that cloudiness of the lens. Just because you have cloudiness of the lens doesn't mean you have to have your lenses taken out.
Is it true, Dr. Eve, that I read somewhere that Black people have thinner corneas, and that's leads us to be more, that's not true. Okay, that was
No,
Dr. Google.
I would say that would be a true statement. We don't have thinner corneas. People that have thinner corneas are usually people that, you know, they may have other eye diseases that make them more prone, like keratoconus is one of those corneal diseases where the cornea is not the thickness that most of other people have. Or if you're very, very nearsighted. And nearsighted is when you can see things up close most easily. And, you know, that means that you might be like a -12. You know, so for instance, Tiger Woods was very, very nearsighted. And so his corneal thickness was really on the thinner side. So when he had the laser refractive surgery to correct his vision in his late 20s or early 30s, you know, they had to be really careful that they weren't going too deep there, right?
So I've been wearing contacts a very long time. Does that have any correlation to, or?
Not really. Contacts, and I used to wear hard lenses up until about 10 years ago, and so it doesn't actually impact the thickness of your cornea, no, but it's a matter of actually seeing that as a way to correct your vision. And usually you can get better vision when you wear contacts versus glasses.
Judy has a question. Judy, did you want to ask your question?
Yes, good day, doctor. You just mentioned a while ago that if there's cloudiness of the eye due to cataracts, if they cannot correct it with lens, then maybe you have to do something about it. Did you mean if they can't give you a glasses prescription to get you back to 2020, then you may need an operation?
It all comes back to you, Judy. So if they can't get you to 2020, that's just telling you, well, and they can only get you, say, to 2040, that's just telling you, well, I have a little bit of a cataract. The question is, can you live with 2040 vision? And I would say 99% of people can live with 2040 vision, because that's at least what you need to drive in every state in the union. You don't need 20/20 to drive necessarily, but it's usually in, at least in most states, at least 20/40. But if you're a pilot, so Judy, are you a pilot?
Not yet.
If you're a pilot, you're gonna say, oh my God, I need not just 20/20, I need 20/15 vision.
Okay.
So then as a pilot, you might say, well, doc, is there something I can do? Well, then that's where a surgical discussion would go, would start. You know, surgery for cataracts has certainly gotten so much better in the last 20 years. It's not zero risk, but it's lower risk. And so you have to weigh the risk versus the benefits. So no one can guarantee you that you're going to go from a 20/40 to 20/20 if you had your cataract operation at that point. And so you have to be ready to take the risk that you may not get to 20/20, but there's a good chance that you would get to 20/20 if everything is perfect in the back of your eye, as well
There's
as
two,
well.
Thank
two
you.
hands are up. I see Kilthea and then Lena. Go ahead, Kilthea.
Oh, hello, Dr. Higginbotham. I had a couple of questions. I was treated a number of years ago, probably more than 10 years ago, for narrow angle glaucoma. And it was explained to me that that was a preventative measure. And I'm not even sure I fully understand what narrow angle is, but I see someone also, Sis Val, posted something about if you could compare closed angle and open angle glaucoma.
Okay, that's a great question. And Helen, I'm going to try and share my screen because I have a diagram of the eye, and that will make it easier for me to.
We see it.
Yeah, I see it.
Okay, let me see if I can get it bigger. Let's see, where's my slideshow? Preview, view, slideshow. Okay. Let's see, where is my slideshow?
It's pretty clear.
Oh, you can see
You
it.
see yours? Okay, yeah.
Okay.
I was gonna say you
Should
see
be
your
at the
Zoom button at
bottom.
the top.
So look on the left-hand side. So I have the cross-section of the eye. And so this is the cornea in the front. We've been talking about the pupil. That's where we dilate the pupil. We talked about that. That's your iris. And then here is your lens. We just talked about that. So the open angle versus closed angle refers to the area just behind the cornea in front of the iris, okay? I can't really show you exactly, but this is the area. So there's a drainage area. So when you have closed angle or narrow angles, that means when we look in with a special mirror, I can't see this corner here. It's closed off by the iris. Does that make sense? And so when we do what we call a laser iridotomy, we're creating a small opening with the laser in the iris tissue here. And that allows this area to open up because fluid doesn't get trapped back here behind the pupil and the lens. It's allowed to flow through this opening so that the pressure in this space here is the same as the space behind here. Does that make sense?
I think so. So can you explain what would happen if that went untreated?
Untreated, yes. That can lead to acute glaucoma. And acute glaucoma, the pressure could go, remember I mentioned 16, could go up to 50 or 60. And you may be having eye pain, decrease in vision, to the extent that the pressure is so high, it can make you sick to your stomach. And you come in with nauseated as well as vomiting, okay? And that can lead to acute blindness. So they did you a favor by creating this opening. using the laser, because that provides a pathway that wasn't there before and reduces that risk significantly.
Great, thank you so much. And the other lady wanted you to compare the two, the open and the closed angle. I'm not sure.
Okay, the open means that when I look in, when I examine your eye, I can see the drainage area. And it's like, if you think about an O-ring inside a pipe, that O-ring, I can see the drainage area in a circle, 360 degrees all around, okay? But if it's closed, I can't see it. The iris, the colored part of the eye, is covering it. And so that tells me that we need to do the laser treatment, the laser iridotomy, or small opening. Otomy just means opening a tiny hole in the iris.
Is that an easy surgical procedure?
It is. I mean, it is for me as a, as a physician, it's easy to do because nowadays we have lasers that can, do it within, 5 minutes, really. Whereas in the old days, we had to bring people to the operating room and create an opening here. But it's easy. So if someone says you have narrow angles and we think you should have the laser treatment, the laser iridotomy, iridotomy, then I would certainly not hesitate to get it done. I would have it done. And then you have to have it done in both eyes because our eyes come in pairs. So whatever's happening in one eye, the other eye is like taking notes.
That's why I'm using drops in both eyes, even though I've only been diagnosed in one.
Yes. Because the other eye that doesn't quite have glaucoma yet is really on that same track. But now that you're taking drops, it's in a better track. So you don't want to leave it untreated since you know what's going to happen. While I'm here, I'm just going to actually stay here just for a little bit. We talked about the lens and the cataract. The optic nerve is where I've been wanting to get to in our discussion today about glaucoma. And as I said earlier, the pressure does not have to be high when you are diagnosed with glaucoma. The important question is the size of the nerve. So this is the optic nerve. This is the optic nerve here. And this is a drawing, which I think very nicely shows you the healthy tissue, the small circle here, indicating that there is healthy tissue around it in this picture compared to this picture. Okay, so one of the key questions that you do want to ask after you know your family history, after you tell them whether or not your vision's changing at all, if you notice any changes, you want to ask them, how does my optic nerve look? Is the cup enlarged? And so this would be a glaucoma cup. One other thing, because I don't want to confuse things too much, but just, I know I said the pressure is not the important thing. It's really the appearance of the nerve, which is all true. But sometimes you can have high pressure, but your nerve is normal, and you still don't have glaucoma. It means that you're what we call an ocular hypertensive, okay? You can still have a normal nerve, but have high pressure. The question is whether or not that pressure is so high, you need to at least start an eye drop to reduce your risk, or just be followed. And that's a whole nother discussion. But I just want to make sure everyone sees this difference between a normal nerve versus a larger nerve. And we call this inner circle here the cup, and this outer circle here the disc. And you might hear the doc say your cup to disc ratio is 0.2, which would be closer to this. That means this circle is about 20% of this circle. Or they might say your cup to this ratio is 0.8, which is closer to this, or this blue circle is closer to the edge of this red circle, or 80%. So that's that kind of gives you at least. I need to get out now. Stop sharing. Yeah. So
Okay.
hopefully that gave you at least a good visual.
Absolutely, absolutely. Lena, you had a question? I don't know if it was related.
Yeah, it's good to meet you, Dr. Higginbotham. I have glaucoma, and I'm right now, I went to get a second opinion about a procedure that my ophthalmologist wants to do. I'm seeing an ophthalmologist at Krieger Eye Institute in Baltimore. And then I went to Hopkins to get a second opinion. My left eye, the pressure keeps going up. And one day it went up to like 28. And then later on that day, using another instrument to measure, the technician got 19 or 20. So she said, well, it can fluctuate, on the same day, like you said, depending upon the time. But my question is, he wants to put in another tube, he said, to relieve some of the pressure. And so I'm wondering, well, what are the treatments? Is that, is that the only treatment that can be used to lower my pressure, is to put in another tube? Are there other treatments?
Well, I'm glad you brought up the treatments, because I did want to get into that too. That's a great question. Let me start with the eye drops first. I just want to make sure everyone knows that before surgery, there are eye drops, and I would say 90% of people, that's all you need.
Oh, I'm sorry. Yeah, I don't want to interrupt, but I'm using all
Yeah.
4 drops.
Yeah.
twice a day.
And we also have pills for the pressure too, so that people might be on. And then once we're not able to control the pressure with that, then usually we go to laser. I'm one that advocates at least trying laser. I know there was a question about laser treatment. So laser treatment, yes, it can work. It's not 100%. Nothing is in this world, but it's a lower risk. And so, Lena, I don't know if you still have any open angle or if you had the laser treatment. So that might be a question, whether or not there may be the possibility, particularly if you've never had it. Let's see, this question is, no, that laser is a selective laser trabeculoplasty. It's called SLT or trabeculoplasty. Goniotomy is something else. It's another procedure. And so, Lena, one of the things I would do is to see if you've never had laser, I would see if there is any area where we might try laser.
Okay.
Depends upon how significantly your pressure is up versus where your field is. That's the other thing we do, is if you've already lost a lot of field, the pressure has to be lower.
Okay.
Yeah. So if people come in and they just have a little tunnel vision of field loss, I need to get that pressure 10 to 12. 16 is going to be too high.
Mm-hmm.
So the visual field as well as the nerve. So the nerve is going to be reflective of what is measured on your visual field test. So when they examine you, which I didn't complete that thought, we look at the optic nerve, we will measure the thickness of the tissue coming out of the optic nerve, because in glaucoma it's thinner, because we have what we call OCT, ocular coherent tomographies. We're measuring the thickness to see. if it's really thin or not. And then we'll also do a visual field where you have to sit and look at a light in the middle and then see if you see
Oh, yeah.
off to the
I've done
side.
Yeah.
So that tells me the function, okay, of how you're doing. So the visual field, the OCT, and the optic nerve exam, those are the 3 key tests, as well as the pressure. So 4. Let's put pressure in there. Now, in your
I
case,
thought-
go ahead. In
Go
your
ahead.
case, because I don't know the details of your exam, I don't know where they need to get to. You know, we set a target pressure. You may have heard target pressure. You might ask the doc, what is my target pressure?
Well, the one I saw at Hopkins, he said he'd like to get it down to like 15.
Okay, so that would suggest that you have some moderate field loss, but you don't have severe. Because if you had severe, they would say 10 to 12.
Oh, okay.
Okay. So if they need to get it to 15 and you're at 28 and you've had laser already, then they may need to do another procedure. And the procedures that we have available now are many more than what we had even 10 years ago. Okay. There is a classic procedure called trabeculectomy
Mhm.
that works best if you never had any procedure done at all. But once they start putting what we call tubes in, then it reduces your success rate to do that trabeculectomy, okay? We also have procedures, and that's one of the goniotomy is an angle procedure where we just treat the drainage area surgically. We're not touching what we call the conjunctiva or the white part of the eye, because that's the tissue that we depend upon, okay, in surgery. So, you know, so that would be another kind of procedure if it's just in the angle. I know it's a lot of detail, so.
A lot of information, but I'm sure people are grasping it.
Yeah.
Thank you, Miss Lena. I hope
Thank
that
you.
answered
And
your.
just want to say to Dr. Eve, I'm glad to see someone who knows about charity where I was born.
Oh, yeah. You're from New Orleans too.
Yeah.
Good. Yeah.
Okay, there's quite a few. Some people are sending questions to me privately. I don't know if you guys are aware of that. But let me, so the one I just posted there, Eve, I don't know, something, let's see, what does it
Let's
say?
see. Well,
I have a
It's
question.
only been explained to me in terms of damage to the optic nerve. Would you ask how the size relates to the damage to the nerve? I don't know if that person wants to ask the question themselves. And then there's, if you want to do that one, and then there's another question. Someone is saying, I went to my optometrist a month ago, and she said my optic nerve is thinning. She prescribed I'm on it, latanoprost. Is that how you say it correctly? Drops, and my numbers were normal. But then she goes on to say, wait a minute, let me find the rest of her message. Where's the rest of her question here? I lost the rest of her question, but anyway, oh, sorry, I wasn't finished. I went to my ophthalmologist and she said, and the ophthalmologist told her to stop the drops. So she's got an optometrist telling her to take the drops and an ophthalmologist telling her to stop the drops. And I know you're going to say, listen to the ophthalmologist.
yeah, well, and it sounds like the optometrist may have just done a test, an imaging test at OCT that showed some thinning, but and then there was another question about the size of the nerve. So the bigger the nerve, that red circle I showed you, the bigger the nerve, the larger the cut. But you can still be normal because you just have a big nerve. Okay. So it may be that when they did the imaging test, maybe you have a bigger nerve, who knows? And so the optometrist was just going by that. But then the ophthalmologist looked at your nerve, saw you had healthy tissue there, and said, no, you don't need these drops. And I don't know if you had a visual field too. And if the visual field was normal, then even more so, you don't need the drops. So it's a matter of actually asking the right questions, knowing that a visual field can be helpful in really determining the health of the nerve, because it tells us how healthy the nerve is functioning, how much the nerve is functioning. Well, we got lots of questions now.
Yeah. What about a third opinion or second opinion or whatever for something
Yeah.
like that?
Yes,
Doesn't
getting
hurt.
additional opinions, as
Right.
you did with the ophthalmologist, yes.
Yeah, we do have
I just
questions.
have
Sis
one other
Val, I
question.
saw your hand first. Go ahead,
Can you
sister.
please tell me what, if any, are the risks of that open surgery to open for closed angle or?
Oh, for the laser rhodotomy, for the
Mhm,
small opening,
mhm.
and I'll put it in the chat so you can Google it as well. But the risk includes increased pressure inside the eye after the procedure, because we're putting a small opening in a tissue that has pigment in it, so that pigment scatters. Okay, so you can have pressure that goes up. That's why I have my patients wait 30 minutes to an hour so we can check the pressure. You'll get inflammation. So after the procedure, you may have to use a steroid drop. And those are or it may actually, you may not, as a physician, we may not be able to actually get through the first time. And so we may say, we need to have you come back so we can do a touch up.
Okay.
Yeah. Does
That
that
answer
answer?
your question, Miss Val, Sis Val?
Yes, thank you. All I can say is wow. Thank you.
Thank you. Glad you're here. Michelle Burgess, Kilthea, and Dre. That's the order that we'll take your next questions in. So go ahead, Michelle.
Okay, thank you. Thank you, Dr. Higginbotham. I think I'm saying that right. So I have a question. I have had eye issues for years, but I want to just ask about a laser surgery I believe I'm going to have in April. It is a band keratopathy in my right eye. It does have a tube in there, and I'm glad you mentioned that laser was your like minimal risk, but I'm having a little bit of eye pain every now and then. And I'm just wondering what might my risk be with the band, the tube in it. And I think I'm saying the band keratopathy. They said it's like there's a band across my cornea. So yeah, I postponed it for a year. Then I was a little nervous. And then I did a Google search on AI and it said 99% effective, but it depends on the doctor and depends on the patient. That's that 1%. Now I went to see one of my specialists and he said, I told him those statistics. He goes, yeah, there's always 1%. I'm like, so that just did not alleviate my fear. So I'm asking you, what can you tell me about that and what might be the risk and should I be worried?
So, first of all, don't worry. And I like your hat.
Thank you.
AKA. So yeah, so you mentioned band keratopathy. So if just imagine that on the very surface of your cornea, there's like calcium deposits on the surface, okay? And that comes from, maybe it sounds like you had some inflammation in your eye, you had surgery because you had a tube. I mean, that's just the inflammatory effects of having undergone surgery and other procedures, okay? So when they go in, they're actually just going just superficially. They're just scraping off the calcium. So I would say, yes, it's low risk, very low risk. And the hope is that you might be able to see better because that calcium, that just think of it like salt on the surface, is interfering with your vision.
Okay, I've also had cataract surgery, so you were right about the other things that I've had. So, okay,
Yes.
thank you. I feel much better.
Yeah,
Thank you very much.
don't put it off any longer.
Okay.
Yeah.
Chicken Little, do it, do it. Thank you. Miss Kilthea, your questions. Kilthea, are you muted?
Yes, I am. Thank you. Thanks. in relation to the previous person that was speaking, I had the one eye done twice, so it didn't take in one of the eyes with the iridotomy. So I did have to do it 2 times. But I'm asked, this question is actually about an older relative. She had a bleed in one eye. She has glaucoma in the other eye, so she takes drops at night in the one eye. The other eye, I take her about every 6 weeks to get a needle in her eye. You would understand that doesn't make sense to most of us, but and now she's in the hospital for something unrelated. She was supposed to have gone for the needle last week. And so I called to cancel and they let me push it out 2 weeks. They said, don't go any further. And I'm not sure if I'm going to be able to take her in 2 weeks or not, but I guess my question is, are there other options other than the needle to the eye, and are they preferred, or is the needle the preferred treatment?
So without knowing the details, I can only guess, but I do have a question. Does she have diabetes?
Well, that's been an ongoing discussion. When I asked her, because I thought she did, she said, oh no, I didn't have diabetes. I did at one point, but then the doctor said, I don't need anything. Well, now that she's in the hospital, that those people are telling me, oh, her sugar's high. We're giving her insulin. So it's kind of, yeah. But
Yeah.
can you address the needle to the eye, because that's like an odd thing for people who have never been involved with that?
So she
Sounds
probably,
really painful.
No, they say it doesn't hurt.
it's diabetic retinopathy. So diabetes can actually lead to blindness if it's not treated in the back of the eye. The best thing for diabetes is to control your hemoglobin A1C. That's the best thing, and be preventive. That's the most important thing. But if it's not controlled, then there are little blood vessels that grow in the back of the eye, and they just go crazy. They don't have any rules or regulations that guide their growth. And so nowadays we have these injections. If you Google anti-VEGF or VEGF, it's a substance that actually can be injected inside the eye, because we need to get directly to those blood vessels and stop the growth. It reduces the growth of the new blood vessels, and that process of where the new blood vessels will grow, and then they start creating a membrane, and then that membrane can pull off the retina.
Oh, okay.
So the injections are very important. It's an amazing advancement in science that we have this, because in the old days, we had to actually take patients to the operating room and apply laser directly. We still sometimes have to do that, but the retina specialist is the one that handles that.
Yeah, that's where I take her. The Will's Eye has a outpost over here in Cherry Hill.
Yes.
Okay, could you put in I tried to put the tests that you told us were the top 4 tests, but I don't think I didn't know, I didn't catch them all. Can you put that in?
Okay, I can,
Thank you, Ms. Kilthea.
Yeah.
Dre, are you ready with your question?
Yes, Helen, thank you. Can you hear me?
yes.
Terrific. This has been very informative, Helen and Dr. Higginbotham. I'm a 60-year-old Black man, and I was just curious because one of the things that I don't hear in the community of men that I surround myself with, we don't talk about glaucoma. And I was wondering whether Black women have a higher incidence of glaucoma than Black men, and if so, what might account for the difference or differences? Just out of curiosity.
So, I was trying to multitask.
I'm sorry, I should have waited for the next
So
question.
yes, so women generally can have a greater likelihood of glaucoma because we live on average longer. And this is a diagnosis of aging, basically. But the other reason, and this is all still somewhat under investigation. I mean, when we look at some epidemiological studies, we've noticed that women that have had hysterectomies early in their lives may have a greater chance of glaucoma. So it's something going on with the hormones, and having that protection of the hormones for a longer period of one's life. So those are a couple of insights there. But I would say that both men and women have risk for glaucoma. It's really primarily aging and family history. Does that help?
That does. Thank you.
You know, somebody had asked, because we were talking about it with people of age. So, a couple of questions. So, at what age should we start taking our children for eye exams? And what is, I mean, I know 40 is the magic year that we should all be seeing an ophthalmologist, but what before then should we, I don't know, I guess, like, what's the magic age before then? Like, because a lot of people think because I don't wear glasses, I don't need to see a eye doctor. And of course, we should know by now that that's not true. So just where should we start? What are the highlights of age where we should be concerned about our eye health, our optical health?
Yeah, so your pediatrician is really the first pass, but also for those individuals that are born prematurely, they and they're in a neonatal unit in a hospital, there is a certain birth weight and a need to use oxygen at certain levels that will trigger an eye exam. So there's some preemies that will have eye exams early. Okay. Pediatrician should be checking the kids' vision, but at the very least, before they go to school, they should have a comprehensive eye exam. And we can determine the glasses that kids will need. There are ways that we can do that. So get them at least examined before they go to school. And just one piece of information that really, I think, is haunting for me is the fact, excuse me one second, is the fact that preschool children and school-age children, there is a growing need to ensure that everyone gets their eyeglasses when they need it, because it impacts how well they do in school, right? And most of the kids in our communities of color are not getting those eyeglasses early enough. And I know, for instance, in Baltimore, at least one of the health commissioners many years ago used to ensure that school-age children who needed glasses had them done. So anybody who has grandchildren out there, make sure that they're at least getting their eyes examined before first grade.
And also, we can talk more about age with glaucoma, because I don't want people to leave this call and think because 40 or 50 or over, because obviously I've talked to a few people leading up to this call who are not in their 40s and they have glaucoma. And one lady said, I have 20/20 vision. How can I have glaucoma? So I don't want anybody to walk away from this call thinking that it's an old people thing, because it's not. Oren, you have a question? Oren? Okay, moving on, Oren.
Since I mentioned kids, kids can have glaucoma, congenital glaucoma. Yes. So if you're a grandparent and you notice that the kid's eyes are big, that's a sign, because up until a certain age, about age 5 or so, the eye pressure will make the eyes bigger. And sometimes it's the grandparents that will notice that. And when they come to see us as kids, we have to operate on kids. with glaucoma. That's the process. We don't put them on drops initially. It's surgery. And the sooner we can do that, the better. And it can be curative.
Is there anything, because sometimes, is there anything that we can look at our eyes and see, like my eyes? Should I have been able to look at my eyes and see like something's going on? One is bigger, one is smaller. For all my life, people have said that I have sparkly eyes or something. They'll say, one of my girlfriends, she's always like, so, it's very interesting. So there's nothing visual externally that we should be noticing.
No, it's only the babies, only the babies that we see, what we call buthalmus, where the eyes get bigger with increasing pressure.
Right. Okay, go ahead, Miss Oren, your question.
Thank you, Helen Higginbotham. And thanks to Camille for inviting me. As I wrote in the comments, so you don't have to go back to the comments, I was diagnosed with very early stage glaucoma. And in lieu of drops, the ophthalmologist suggested laser, which I've had, and that worked well. My question is, does laser have to be redone like every, I don't know, 5 years, 10 years? My field of vision is fine. I have the 20/20, but I'm just like, do I have to go through that again? Do I have to look forward to going through laser again? Thank you.
And you were one of the first questions we had, so thanks for bringing it back up. So yeah, laser treatment is a great first step. And in some parts of the world, they'll do it as a first procedure before meds. So you have a very progressive ophthalmologist, so that's a good thing. The risk for at least the effect wearing off is about 10% per year. Okay, so it doesn't last forever. You do need to be monitored. It doesn't
And I
necessarily,
am.
yeah, you don't
Every year
necessarily,
I'm monitored. Yeah.
oh, good. You don't necessarily have to have it repeated, but the kind of laser we do these days, you can repeat it.
Okay.
Yes.
Thank you.
Not that I had laser until somebody mentioned that laser didn't work for me, which is unfortunate. Thank you, Miss Oren. Come again. So good to see you. Miss Bay, you have a question.
Yes, Helen, good afternoon, family. I wanted to know, here lately, I'd say it's been going on a couple of months now. I am waking up with my eyes extremely dry. Sometimes I can't even open them. I do, when I look in the mirror, I see like a gray cloud around my the black pupil of my eyes. I'd say 5 years ago, I was prescribed glasses. So now I do wear glasses at the age of 70. So at 65, that's the first time I've ever had glasses. But what I'm doing, I have a bottle of alkaline water beside my bed. So if I wake up in the middle of the night, just using the bottle like an eyedropper, an eye cup, and putting water in my eyes. I have to, in order for them to open. This is almost like every night, along with that, my mouth would be very, very dry, So what is going on with that?
Well,
The dry eye.
without having the details, of course, you may have what we call Sjogren's disease, where you have dry eyes and dry mouth.
Uh-huh.
And so that's one thing to think about. It sounds like you've already established that you have dry eyes, but you have dry eyes to the extent that they're waking you up at night. So that's
no. If I get up to go to the bathroom, I'll find that or when I wake up in the morning, I'll find that I can't open my eyes because they're so dry. And putting the water in, is that sufficient?
I would not recommend putting water in your eyes just because, you know, water has stuff in it. And so it's
Now
best
I'm using the alkaline water,
the alkaline water.
you know.
It's still not water in bottles that are programmed to be used for eyes. That's my concern.
Okay.
But and so what you need to have a conversation with your ophthalmologist about this, because there's just so many things that actually can contribute to what you're experiencing. So one of the things until then, you can think about going to the drugstore and getting an artificial tear ointment.
Uh-huh.
Okay, now it's going to blur your vision when you get up in the middle of the night, but it's going to do a better job of keeping your eyes moist while you're sleeping.
I see.
So
And you would put that in before you go to sleep?
That's right. Put that in before you go to sleep.
Uh-huh.
Then during the day, put the artificial tear drops in, and they're different levels of drops that some are thicker than others. So you need to kind of experiment. Liquid film tears might be a little bit thicker. I mentioned earlier Systane over the counter, and you can put these drops in every 2 hours or even every hour if you need to. But the ophthalmologist can also prescribe medications that can help with the dry eyes, like Restasis is a very common drug available now that helps with some of the basic mechanisms related to the dryness.
Okay.
And the last thing I mentioned.
Okay, we gotta move on, Miss Bay. You know, we got other questions here, but thank you for your question.
Right. I just wanted to know the opinion on the marijuana with the eyes. Not that I'm looking to smoke anything, because I don't want any smoke going into my lungs, but what is your opinion? Thank you, Helen.
Okay.
Thank you.
Yeah, well, let me just say one other thing about your eyes. You also want to make sure that your lids are not secreting too much oil and aren't inflamed. And so that's where baby shampoo, lid scrubbing can help too. Now on the cannabinoids, marijuana, yes, while you're smoking it, it works. It absolutely works while you're smoking it, but
that's what I was told. Unless you want to smoke it all day. And some people, Snoop Dogg might want to smoke it all day.
I know. And all these other, you know, the pills and the munchies, I mean, it all really has to get to your eye. So
yeah. That's what Dr. Monster said. She said, yeah, while you're using it. That's exactly what she told me. And I'm going to call on you next, CB, but I'm glad that Miss Bay asked the question. So I use the drops, as you know. Does it matter what time of day you use the drops? Must I use them at night? Because sometimes I fall asleep and I wake up in the morning and I'll take out my contacts and do them. Does it matter what time of day I'm doing the drops?
Yeah, on the latanoprost or any of the drugs in that category, when we did the clinical trials, it seemed to work better at night. Yeah. And so, yeah, it does matter, but if you miss a drop, it lasts for a couple of days.
Okay, great. CB, you have a question.
I do. Thank you, Doctor, for the discussion, and Helen for everything you do. My question is, we all know that a lot of screen time is bad for our eyes. My question is, what behaviors and what nutrition, what things can we do that really are good for our eyes? Thank you.
Good question, because somebody else asked about diet. Does diet make a difference? Is there anything we can do diet-wise? So thank you, CB.
Yeah, that's a great question. So screen time, the thing that actually is problematic is when you have the dry eyes, because when we're using the screens, we're not actually blinking as much. When we blink, that's when we moisturize our eyes. So if you're at a computer for long periods of time, you want to use the rule, the 20-20-20 rule. You want to, look away for 20 minutes, or look away 20 minutes or 20 seconds after 20 minutes, and in a distance, and then give your eye a rest. And then you can also use artificial tears more often while you're using your the computer. Fish oil certainly has been suggested as being helpful for dry eyes. And then having a good balanced diet with good greens is also good, particularly for macular degeneration. So I would say a balanced diet, but fish oil, some people actually swear by it. But using artificial tears frequently, or any of the medications we mentioned, like Restasis, or other things to try.
How are they using fish oil? Like over the, because you said
the tablet, tablets. I'm sorry.
okay, we're gonna put oil.
Yeah,
Okay,
I'm glad.
so
Thanks for the clarification, Helen. The
okay.
tablet.
Somebody else had that question. Good.
Okay.
And you also said for the external, you said the baby shampoo.
Baby shampoo. So baby shampoo. I mean, there's also over-the-counter lid scrubs, but the baby shampoo is cost-effective, and it's the shampoo, not the oil. So you dilute the shampoo like 50-50, and just scrub your eyelids with use a cotton swab. And and that helps, because when your eyes are dry, you build up a lot of debris around the lid margin.
So is it too late for me to start eating carrots?
No,
Or
it's
is that a
never
wives'
too
tale?
late. But greens, it's those collard greens. We got to
Collard
get back
greens.
to our roots and eat more
Okay.
greens. Yeah.
Somebody had on here, and I'm going to let you go. This is going. Thank you so much for your time and your patience.
I could do another 10 minutes.
Okay, the response has been really good. Dietrich, go ahead with your question, please.
Hi,
Somebody asked about floaters, and I'm sure everybody has. I have floaters, so you can talk about what floaters are. Go ahead, Dietrich.
So I was diagnosed with early stage glaucoma, and there's nothing to do but watch. But I put castor oil on my eyes at night. Is that good or bad? Because I know they say oil is not good, and I know that's the oil, but to me it's helping with dryness.
What do? Just rub it on top of your eye?
Yes, just rub it across your eyelids on the outside.
Yeah, I guess the thing I would be concerned about with the oil is just the buildup. I mean, because we're already concerned about secretions, normal secretions from your sebaceous glands. Think about, the years when you may have had acne early on. It's like having more oil, accumulate and apply to your lid margin. So I would have some concerns about that. And without having the benefit of examining you, I can't really say if there's a real issue. But I would try the artificial tear ointment that is made to put into the eye.
Okay. Judy, real quick.
Yes, doctor. One follow-up to what Kilthea was talking about. Are those injections then required for the rest of your life? The ones that have to be done every 6 to 8 weeks, the retinopathy?
Oh, that's a good question. I'm not a retina specialist, and
okay,
the literature on how long it really is evolving. I mean, there's still ongoing clinical trials. We know it's effective, and they may try it for 6 months, but they're also measuring the thickness of the tissue in the back of the eye when they do CT. So it may not be for the rest of your life, but I can't tell you how long.
Thank you. And then the second thing was with regards to the dry eye. I've been told about warm compresses.
Yes. Yeah.
Okay.
For the eyelids. Yes.
Yeah. Thank you.
Yeah. that helps those, just think about your glands getting plugged up. And so when you have dry eyes, you can get like a lot of secretions around your lids, and the warm compresses helps to keep those glands working.
Thank you so much.
I'm gonna call my cousin out because he sent me a chat that he's taking his mom to the doctors. He's your cousin too. He's a Higginbotham.
Oh,
Godfrey, I'm calling you out. Godfrey, did you have a question for Dr. Eve? You can say no.
So no question, but yeah, since I am taking my mother to get another procedure on her left eye, and just her history, she started off with the eye drops, and I remember commenting to her, hey, won't you ask the doctor about the next step, which I'm pretty sure is going to be laser treatment. And let's just cut to the chase. So, background, yes, she was having some issues with pressure behind her eye, and I don't recall her number, what that number was. But I said, yeah, you probably need to get that looked at and find out what's going on. And then I say that my background as a healthcare administrator, I've always told her, stay on top of your health. But and to everyone, as just as a statement, for our loved ones who are getting up there in age, we have to make sure that we follow with them on their various appointments. We all know when we get those phone calls, when we call to check up on them, they always tell us about their doctor's visits, the prescriptions that they're taking. And so, I think it's upon us to make sure that we, in turn, follow up with them to make sure they're following up on their care and getting the best treatment possible. So that's my comment. But thanks, Dr. Eve. Great discussion. And yes, we may have to look at the family history and see where you fall. Ideally, the Higginbothams that Helen is related to and I are related to are out of Amherst, Virginia, and I forget the part of South Carolina. So I have not seen any connection to New Orleans, but we never know.
Yeah, and always, I think we can trace a lot of our roots back to Virginia, right, as a community. But I think Virginia was one of our lines as well. Yeah.
We have information from you.
We'll have to compare notes. As far as I know, the notes. Yeah.
Okay.
Okay.
I love it. Thank you, Godfrey. Charlotte, we're going to thank you so much, Godfrey. Charlotte, you have a question real quick? Charlotte. Okay, her hand is up and she's usually here. Real quick, let me scan through the chats before I let you go just to see if there's anything outstanding. The floaters. Did you talk about the floaters?
Oh, I didn't mention the float. Yeah, so floaters. So when I showed you that,
somebody saying the flashing. Somebody here just put in the chat.
And flashing. Okay, so when I showed you that picture of the eyeball, just imagine in the center of that eyeball, there's what we call vitreous. It's like jelly. So when you're born, it's more like Jell-O. Remember Jell-O? I don't know if anyone still eats Jell-O, but as we age, it becomes more like water. The consistency changes, and it starts, and that process can happen where there are clumps that occur. So it doesn't all happen perfectly, like Jell-O turning into water. And so the floaters are the little clumps that we can see because our retina in the back is taking pictures of what we can see. And so we can see those floaters in the gel. The concern is because that gel, when we're younger, it's really helping to keep the retina on the back of the eye. So as the gel pulls away and changing its consistency, it can actually pull the retina. So that's why if you see a lot of floaters, an increase in floaters, or shadows or curtains coming into your vision, you need to have a dilated eye exam immediately. I mean, that's really immediate emergency kind of visit.
Yeah, it's interesting because that happened to me, and I called. I was living in Harlem at the time. I called my doctor in Jersey, and he said, and I went to the doctor there in Harlem, and they were like, it comes with age. Don't worry about it. So that was a red flag, maybe. I don't know.
Did they do a dilated eye exam or? Yeah, I mean, you have to, if there's new floaters and the flashes of light are even more concerning, you know, because that means that it really is pulling on the retina.
Wow.
So it's
And then
always
I end
better
up
to
with
at
a
least have
torn
it.
retina. Wow,
Yeah.
that's interesting. Very interesting.
Helen, I
Uh,
worked out, Helen,
Go ahead,
something
Charlotte.
had happened to my audio. Doctor, this has been extremely informative. I'm glad I joined. What about folks with watery eyes? I have a friend whose eyes just like, she just suffers from watery eyes.
Yeah, it could be. So in your, you know, we have the drainage here, just on either side of the nose. And so sometimes that can get clogged. So that would be one thing to have checked if the drainage is working well. But sometimes that's the way dry eyes can actually happen, or at least present themselves, because we have, I usually say that we have two types of tear glands. There's a tear gland that just kind of pumps water out occasionally to keep everything moist. That's the tear gland that doesn't work as well as we get older. And then there's a second tear gland that just pushes out. It goes from 0 to high. You know, so that tear gland is trying to make up for the lack of the other tear gland. And so it could be one of two things. It could be a blocked duct, lacrimal duct, or it could be that she needs to put artificial tears in on like 3 to 4 times a day to reduce the increase in flow.
Thank you so much.
That's interesting. My eyes have always been teary. Just always. People like, and it's interesting because just if I get cold, they run. So which is really hard in the winter because it's like
Mother was like
cold.
that. Yes.
But at least you get to see people are kind because people will say, "Are you okay?" I'm like, "Yeah." So at least people still have humanity.
But when
People
it's
ask me if I
cold,
cry.
there's very little humidity, so your eyes are dry. So your eyes are competing with the atmosphere for moisture. And so that's
And
why
one
you put
doctor
some
suggested
artificial
I could.
tears.
One doctor suggested a surgery where I could close the ducts. I'm like, I'm not that worried about it. So, something about shrinking the ducts or something.
That's the other thing. If there was one last message to have, and that's, you know, just ask questions, because I see people getting surgery they don't need, or surgery too early, then they come in and they have complications. Or, you know, because doctors are human too. So it's a matter of actually having the right questions on hand so you can make the right decision for yourself.
And I would say also don't shy away from getting another opinion. If a doctor has a problem with you, and honestly, that's how I found out I had glaucoma, because the first ophthalmologist I went to, he actually scratched my cornea, and I didn't appreciate his response to it, so it triggered me to not trust the rest of what he had done, which took me to another doctor who was very indifferent. And honestly, I went to a third doctor, and it was a female, and she said your retina is fine, but you have glaucoma. And that was the first time I ever had a visual field study or anything of that sort. So we had a call a few weeks ago about being proactive in our healthcare. And oh, we got to ask you this one. Somebody says, "What about these girls wearing these false lashes?" Because they're putting
It's a
glue.
trend.
They're putting glue right here, aren't
I know.
Are we seeing, are you seeing an increase in infections or anything?
Not really, because of course, as a glaucoma specialist, most of my patients are of a certain age. So, but there are occasions where I do get someone with the big lashes, and it's hard to examine their eyes. It's really hard.
I only imagine.
So, I mean, I don't know. I don't know if anyone's done a long-term study of glue on eyelids, but it's just a
Crazy.
matter of hygiene, I think, making sure that you do what you can to keep the area as clean as possible.
So look, I so appreciate your time, so I'm not going to abuse you. I'll let you go. I'm going to bring everybody on screen real quick, take you and I off of Spotlight. Do I have my, did I do
It's
that?
been
Oh,
a
no, I'm still.
pleasure. I know Helen's been trying to connect with me for a while, but my schedule is such now that I have more time. So I'm happy to be part of your conversation today. So thank you.
No,
Thank
I
you.
so,
Thank
yes.
you so much.
If you all can unmute and give Dr. Eve some love, that would be great. Because it's been great having you. Yeah.
And I'll put
Yes,
my
thank you. Thank you, doctor.
email. I'm putting my email in
Thank you so
chat in case anyone has follow-up questions and
on the whole
you know,
time.
sometimes the other thing about going to the doctor is if you say things like, well, my friend is an ophthalmologist and she may want to know a little bit of something about what you said, you know, because sometimes, you know, it just helps to pull a name out of the hat. So feel free.
Absolutely. Thank you so much. And and also I think let me ask you this before we go. Do you think well, not that it matters, but having a Black doctor is more advantageous, would you say, or
I
doesn't
think
it?
so. I think so.
I'm glad you asked that question, Helen.
Yeah,
Thank you, Dre.
because first of all, we love everyone, but I particularly love people that look like me because I feel like you're part of my family.
Right. Right.
And you know, there are good doctors who aren't part of our community, but I think having that connectedness is important.
And I'll share that when all this happened, I circled back with my optometrist and explained to him how disappointed I was in him. I had been seeing him for 12, 13 years, had no reason to even question the care that I was getting. And, he told me about, there was no reason for him to explore it any further because he didn't see the pressures, but I said yes. But now I understand that I'm a Black woman. I'm over 40. Like those were so a Black doctor may or may not have understood those as red flags, but I would like to think that all doctors are looking at us from a race-based perspective, but they're not. So that's why I say does it make a difference to have a Black doctor? So yeah.
Yeah.
So
Well, it's
anyway,
important
thank
to know
you.
your family history. So that's the
Yes.
key.
Yes,
Well, thanks
that was
everyone.
key.
This has been great.
No,
And
thank you.
Thank you so much. This was very helpful. Thank you.
Right.
The recording going to be available?
Helen, is there a list
Yes,
of Black doctors of ophthalmology? A list or an
the National
association?
Medical Association, I don't know if they have a website, but there are about 200 of us in the country. So
What was it called? The National what?
Medical Association,
Oh,
the NMA is the Black physicians. So they may have a list, I'm not sure, but I can look into it.
okay. All righty. So before we let Dr. Eve go, can we just unmute and do what we do every week? And then I need you to hang around because I got to ask you something. But so when Black women gather, what happens?
Amazing things can happen.
Welcome to Your Amazing.
Welcome to our amazing. So thank you
Yes,
for being a part of
you
our
are
amazing
amazing.
Dr. Eve.
Well,
And I will
thank
circle.
you. It was my pleasure, and you are amazing. So thank you.
Thank
I will
you.
circle back with you and get some more information. But thank you again.
You're welcome. Take care.
All right.
Bye-bye.
Bye-bye.
So I'm going to stop recording. If I can find the stop recording button.